after this, they're no longer, a lot of people tell me when I ask them how they do their exam, that they will just start at wherever and just start going through and writing everything down, and then they go look at it and they try to figure it out. Here's why, and a lot of times very left-brain people like doing that, excuse me, but I don't care how your brain works, that is not the most efficient way to do it, and hopefully you're going to see why. Here's what you need to be doing. First, you already talked to them, so you're pretty sure where the problem is. This is going to fly in the face a little bit of what Clasper said, but I'm not exactly talking about the same thing. You don't want to do a complete exam of every single exam that you know how to do on somebody who will be in there for like 3 hours, right? What you want to do is, all right, now I have a general idea of where the problem probably is. So let's say I'm thinking that it's a vestibular system. I'm going to talk about that yet. It doesn't matter. Let's say I'm thinking vestibular system. You want to start doing a bunch of tests on the vestibular system. And if you're right, and you've got a whole lot of findings on the vestibular system, that was step 1. Step 2 is what? What fires into it? Because that thing could be lesion causing whatever you're looking at to have findings. So then what you want to be thinking about is not just, I'm just going through my exams. Up there, so we said the cortex fires to this midbrain and this IML. If I'm having findings in the midbrain, do you think it might be more beneficial to go now to the vestibular system or maybe the cortex? Maybe the cortex, right? Because what you want to be thinking about before you do each exam is, what am I expecting to find before I do it? Right? You want to already be thinking what is probably going to happen before you do it. Okay? That way, you're not just blindly just doing exams. You're thinking about it, trying to figure out what the problem is as you're going, and you're doing the exams that need to be done. Maybe you don't really need to be doing all these other exams that you normally do. But then once you're done, and you're pretty sure you know what the primary lesion is, you have to do a few exams globally. You have to, so that you know how every part of the brain is doing. Because if you don't, and you try to start stimulating, I'll talk about it over here in a second, but if you want to excite this midbrain, and you're going to do complex movements, those of you know what I'm talking about, through the cerebellum to get there, but you didn't check to see if the vestibular nuclei that the cerebellum also fires into is lesion. Now you're overstimulating something that was lesion and can't handle it. Now that person's going to go home and just be terrible. So, and that happens. I've seen it quite a bit. So you need to do a few tests globally just so that you know, do I need to take a different route to try to rehabilitate whatever I'm looking at. Does everybody kind of see what I'm saying? It's really important. Okay. This is the most powerful pathway through the brain. So it's something that you should just memorize. It's really not that much. The afferentation pathway, all right? If you're not familiar with this drawing, it's like a slice A to P view. This is the mesencephalon, this is the pons, medulla, that's the cerebellum behind it. That's obviously the cortex. All right. So let's say I do a finger adjustment over here on the right. Stimulation is going to come in. Now, is this the only place it's going? Of course not. I'm just giving you the main pathway. Okay. It's going to the ipsilateral cerebellum. Contralateral midbrain. contralateral cortex, its ipsilateral pons, back over to the cerebellum. Now, the reason it's so important is because you may hear sometimes the story of somebody doing an upper cervical adjustment and the patient threw up on their shoes. And that's what the nape needed to do. Do you think your body's reaction is ever good by throwing up? Probably not. The reason, let's say this person has a left mesencephalic lesion, all right? It's pretty fragile. If this loop, the stronger stimulation you give it, not only does it hit these areas up, but it will continuously do this loop. So the stronger the stimulation, the more it's going through this loop. So you're just hitting this thing up, hitting it up, hitting it up. As far as, now I'm talking about joint mechanoreceptor stimulus. That's the strongest stimulus that you can do naturally, okay? Using proprioception, I'll talk a little bit, but using proprioception, like contralateral movements, that's less than doing an adjustment. That's why we do it when somebody's fragile. That's why you see maybe in the CBC somebody doing that. But as far as joint manipulation, the joint mechanoreceptors, the more distal, the less stimulus to more superior. But I'm talking about distally to proximal. So just because my elbow is higher than L5, there's more joint mechanoreceptors in L5, so you're going to get more stimulation. So peripheral to proximal. So if you do this upper cervical adjustment, C1, that is the most stimulus you can give to somebody. So their lesion over here, do you think an upper cervical adjustment that's not only going to give it a stronger stimulus, but it's going to just keep hitting it up and hitting it up? Is that a good idea?
Sorry. Could you label those parts again on the diagram there?
So this is your brainstem basically. The medulla, the pons, and the mesencephalon. And then it's like an A to P view. And this is the cerebellum looking at you from the back.
Okay, thanks.
So maybe, excuse me, and this is what you want to be able to get out of basic club. Even if you don't go to advanced club, you should be able to know what the major parts of the brains do, how to test for them, and understand this thought process so that if you get this patient and he's got this lesion right here, either if it's really bad and you think maybe that you just don't want to deal with it, like you don't want to stimulate it, maybe you take a contralateral contact point and send more of the stimulation the opposite direction. Or maybe, well, I'm getting way off topic. But do you think maybe you could do maybe like a finger adjustment first and give it a little bit of stimulus? Maybe another finger adjustment, a little bit of stimulus. Now he's doing a little bit better. Now maybe he can handle an adjustment. Does that make sense?
It's better to start with the lowers, for example. It's less input.
L5 is less than L4, which is less than L3, all the way up spine.
So sometimes it's
Some people bet what they need is a upper cervical C1 adjustment. But not everybody, right? Maybe that is what that patient needs. But you are going to be able to actually scientifically examine that person and know what their brain is doing and not have to guess. You know. The more tricks in your bag you have, people don't come off assembly lines. Everybody's different, right? The more stuff you know, the more you're going to be able to do. But again, even if you don't want to get into advanced club, we really want you to be able to leave basic club to be able to do this with your patients and understand, does this area, do I need to prime it first with some smaller adjustments or some complex movements? Maybe it's not, maybe you don't even think of finger adjustment. That might be too much. Complex movements first. Whatever. But we're going to keep talking about this thought process as the quarter goes, but I just want to give it a good head start. And what we're going to do at the end, after I tell you how to test for the midbrain, you're going to take your cortex tests, your PMRF tests, your midbrain tests. You're going to get in like groups of 3, 2 people, a doctor, 1 person, a patient, and so you can talk about, are you seeing the same things? Test the person, not just randomly doing these tests. What am I expecting to see when I do this? You know, and then you're going to try to localize a week, and hopefully we're going to keep doing that week to week. Is there any questions before I start talking about testing the midbrain? Ask me if you got it.
So, say you want to start with finger adjustment because you suspect that we need instead of midbrain. Would you do a finger adjustment and then reanalyze while you're testing again, or just do another adjustment?
Very, very good question. I'm very glad you asked that, because I kind of forgot to talk a little bit about it. Actually, Plasker talked a little bit about it himself. A very important thing when you're treating somebody is to have biomarkers to examine where you're going. And one of them, we really talk about this in advanced club when you're treating like advanced kind of patients that are kind of going to, you know what you're doing. You want to, let's say the person, whatever their issue is, they have a posture. You're treating them and it's getting a little bit better. Whatever you're doing, if the posturing starts coming back, it's probably bad, right? Autonomics is the best thing until you get to where you're like, you feel like you know what you're doing. A pulse ox, if there's one thing you want to spend some money on, get a good quality pulse oximeter. So when you're doing whatever you're doing, you have it on the patient, and then you can see if their heart rate's going up, their heart rate's going down. The other thing is pupils, right? Pupils are very good indicators of metabolic, what's going on with metabolic. One more thing, sorry, that I just want to, I'm not anything else, but another thing that you want to have in your thought process, we're about to break out and we're going to do all these things that we know, we're going to put them up there. Try to get into, if you get into too big a groups, not everybody's able to do everything, but you want to have at least 2 doctors to try to discuss and not seeing the same stuff. You're going to do all the tests that you know, but that thought process of what fires into what, again, right now we're just going to talk about thinking about it with the most important pathways as far as firing. Let's say there's a lesion, you're thinking in the left pons. Which side cortex would you expect to also have findings? Same side, right? So what I literally do when I'm examining somebody is I take that picture and stick it on their face. So I'm just seeing my cortex, mesencephalon, cerebellum, pons. I'm looking at that triangle. So if I test this area, or let's say like I just said, when I test this area, I'm thinking, all right, well, what all fires into it? Right now, we only have 3 areas that we know how to do, so there's only so much you can do with it. But when we learn a lot more areas, what all fires into it? Okay, let me do my cortex test. I'm thinking right now, I'm expecting to have some showings on the left side. Let me tell you right now, hardly ever does everything just perfectly line up in here. But that's why the more tests you do, the better. What you might see is if you do a battery of cortex tests, you might have like 5 showing over here and 2 over here. These are just kind of anomalies you're going through. Does that make sense? So as you're doing these tests, I'm thinking, I'm probably going to see this. If I don't, it's the complete opposite. I'm thinking, I probably did I do something wrong? Like, am I doing the test right? And you're thinking this out as you're doing it instead of just randomly writing stuff down, going home and trying to figure it out. All right, so by the time you're doing your exam, one, you're doing way less exam stuff. You're going to get done with the patient a lot faster. And two, you're already thinking about treatments and like you already know what's going on by the time the exam's done. You're like, bam, this is what you got. This is what we're going to do with it.